Lewis's Medical Surgical Nursing, 11th edition. Chapter 8. Pain. Pain is a complex, multidimensional experience that can cause suffering and decrease quality of life. Pain is one of the major reasons that people seek healthcare. To effectively assess and manage patients with pain, you need to understand the physiologic and psychosocial dimensions of pain. Pain is interrelated with many concepts. Culture and spirituality influence the expression of pain. Acute pain adversely affects mobility and sleep, leading to fatigue. Having pain is a stressor that can lead to depression. Those with severe or chronic pain are more likely to describe their health as poor and have increased mortality. This chapter presents evidence-based information to help you assess and safely manage pain in collaboration with other interprofessional team members. Magnitude of pain problem. Millions of people suffer from pain. Each year in the United States, at least 25 million people have acute pain because of injury or surgery. Common chronic back conditions, such as arthritis, migraine headache, and back pain, affect more than 1 million American adults. Of the 1.7 million people diagnosed with cancer each year, about 60% have pain during treatment. Despite the high prevalence and cost of acute and chronic pain, inadequate pain management occurs. Consequences of unrelieved acute pain are shown in Table 8.1. Definitions and dimensions of pain. In 1968, Margot McCaffrey, a nurse and pioneer in pain management, defined pain as whatever the person experiencing the pain says it is, existing whenever the pain says it does. The International Association for the Study of Pain, IASP, defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. These definitions emphasize the subjective nature of pain, in which the patient's self-report is the most valid means of assessment. Although understanding the patient's experience and relying on his or her self-report is essential, the view is problematic for many patients. For example, patients who are comatose or who have dementia, patients who are mentally disabled or challenged, and patients with expressive aphasia have varying abilities to report pain. In these instances, you must include nonverbal information, such as observed behaviors, into your pain assessment. The emotional distress of pain can cause suffering, which is the state of distress associated with loss. Suffering can result in a sense of insecurity, lack of control, and spiritual distress. It is important to assess the ways in which a person's spirituality influences and is influenced by pain. The meaning of the pain to the person is important. For example, a woman in labor may have severe pain, but can manage it without analgesics because for her, it is associated with a joyful event. Moreover, she may feel control over her pain because of the training she received in prenatal classes and the knowledge that the pain is time-limited. In contrast, a woman with chronic, undefined musculoskeletal pain may be stressed by thoughts that her pain is not real, is uncontrollable, or is caused by her own actions. Perceptions influence the ways in which a person responds to pain and must be included in a comprehensive treatment plan. Some people cope with pain by distracting themselves. Others convince themselves that the pain is permanent, untreatable, and overwhelming. People who believe their pain is uncontrollable and overwhelming are more likely to have poor outcomes. The biopsychosocial model of pain includes the physiologic, affective, cognitive, behavioral, and sociocultural dimensions of pain, Table 8.2. Families and caregivers influence the patient's response to pain through their beliefs and behaviors. For example, families may discourage the patient from taking opioids because they have preconceived notions and fears that the patient may become addicted. Understanding these beliefs helps you address them through patient and family teaching. Pain mechanisms. Nociception is the physiologic process by which information about tissue damage is communicated to the central nervous system, CNS. It involves 4 processes: 1. Transduction, 2. Transmission, 3. Perception, and 4. Modulation. Transduction involves the conversion of a noxious mechanical, thermal, or chemical stimulus into an electrical signal called an action potential. Noxious, tissue-damaging stimuli, including thermal, e.g. sunburn, mechanical, e.g. surgical incision, or chemical, e.g. toxic substances, stimuli, cause the release of chemicals such as substance P and adenosine triphosphate, ATP, into the damaged tissues. Other chemicals are released from mast cells, e.g. serotonin, histamine, prostaglandins, and macrophages, e.g. cytokines. These chemicals activate nociceptors, which are specialized receptors or free nerve endings which respond to painful stimuli. Activation of nociceptors results in an action potential that is carried from the nociceptors to the spinal cord primarily by small, rapidly conducting myelinated A delta fibers and slowly conducting unmyelinated C fibers. In addition to stimulating nociceptors, inflammation and the subsequent release of chemical mediators lower nociceptor thresholds. As a result, nociceptors may fire in response to stimuli that previously were insufficient to elicit a response. They may also fire in response to non-noxious stimuli, such as light touch. We call this increased susceptibility to nociceptor activation peripheral sensitization. Leukotrienes, prostaglandins, cytokines, and substance P are involved in peripheral sensitization. Cyclooxygenase, COX, produced in the inflammatory response, also plays a key role in peripheral sensitization. A clinical example of this process is sunburn. This thermal injury causes inflammation that results in a sensation of pain when the affected skin is lightly touched. Peripheral sensitization amplifies signal transmission, which in turn contributes to central sensitization, discussed under dorsal horn processing. The pain from activation of peripheral nociceptors is called nociceptive pain, described later in the chapter on page 106. Therapies that change either the local environment or sensitivity of the peripheral nociceptors can prevent transduction and initiation of an action potential. Decreasing the effects of chemicals released at the periphery is the basis of several drug approaches to pain relief. For example, nonsteroidal anti-inflammatory drugs, Nsaids, such as ibuprofen, Advil, exert their analgesic effects by blocking the action of COX. See figure 11.4. Transmission. Transmission is the process by which pain signals are relayed from the periphery to the spinal cord and then to the brain. Nerves that carry pain impulses from the periphery to the spinal cord are called primary afferent fibers. These include A delta and C fibers. Each is responsible for a different pain sensation. A delta fibers conduct pain rapidly and are responsible for the initial sharp pain that accompanies tissue injury. C fibers transmit painful stimuli more slowly and produce pain that is typically aching or throbbing. Primary afferent fibers end in the dorsal horn of the spinal cord. Activity in the dorsal horn integrates and modulates pain inputs from the periphery. The movement of pain impulses from the site of transduction to the brain is shown in figure 8.1. 3 segments are involved in nociceptive signal transmission. 1. Transmission along the peripheral nerve fibers to the spinal cord. 2. Dorsal horn processing. And 3. Transmission to the thalamus and cerebral cortex. Drugs that stabilize neuronal membrane act on peripheral sodium channels to inhibit movement of nerve impulses. These medications include local anesthetics, e.g. injectable or topical lidocaine, bupivacaine, sensorcaine, and anti-seizure drugs, e.g. gabapentin or Neurontin. Transmission to spinal cord. The first-order neuron extends the entire distance from the periphery to the dorsal horn with no synapses. For example, an afferent fiber from the great toe travels from the toe through the fifth lumbar nerve root into the spinal cord. It is one cell. Once generated, an action potential travels all the way to the spinal cord unless it is blocked by a sodium channel inhibitor, e.g. local anesthetic, or disrupted by a lesion, such as a dorsal root entry zone lesion. The way nerve fibers enter the spinal cord is central to the notion of spinal dermatomes. Dermatomes are areas of the skin that are innervated primarily by a single spinal cord segment. The distinct pattern of the rash caused by herpes zoster, shingles, across the back and trunk is determined by dermatomes, see figure 23.7. Different dermatomes and their innervations are shown in figure 55.7. Dorsal horn processing. Once a nociceptive signal arrives in the spinal cord, it is processed within the dorsal horn. Neurotransmitters released from the afferent fiber bind to receptors on nearby cells. Some of these neurotransmitters, e.g. glutamate, substance P, produce activation. Others, e.g. Y-aminobutyric acid, GABA, and serotonin, inhibit activation of nearby cells. In this area, exogenous and endogenous opioids, e.g. Nsaids, B-endorphin, play a vital role by binding to opioid receptors and blocking the release of neurotransmitters, especially substance P. They produce analgesic effects similar to those of exogenous opioids, such as morphine. The neurons that project to the thalamus are called second-order neurons. Increased sensitivity and hyperexcitability of neurons in the CNS is called central sensitization. With central sensitization, the central processing circuits are altered. Peripheral tissue damage or nerve injury can cause central sensitization. Continued nociceptive input from the periphery maintains it. Figure 8.2. In some cases, central sensitization can be long-lasting due to multiple changes that occur in the periphery and CNS. Because of the increased excitability of CNS neurons, normal sensory inputs cause abnormal sensing and responses to painful and other stimuli. This explains why some people have significant pain from touch or tactile stimulation in and around the area of tissue or nerve injury. We call this allodynia, pain from a stimulus that is not typically painful. It also explains why some people have hyperalgesia, an exaggerated or increased pain response to noxious stimuli. With ongoing stimulation of slowly conducting unmyelinated C-fiber nociceptors, firing of specialized dorsal horn neurons gradually increases. These inputs can lead to the sprouting of wide dynamic range, WDR, neuron dendrites, and the induction of glutamate-dependent N-methyl D-aspartate, NMDA, receptors. This results in an increased capacity to transmit a broader range of stimuli-producing signals, which are then passed up the spinal cord and to the brain. This process is known as wind-up. Activation of NMDA receptors also plays a role in wind-up. NMDA receptor antagonists, such as ketamine, Ketalar, potentially interrupt or block mechanisms that lead to or sustain central sensitization. Wind-up is like central sensitization and hyperalgesia in that it occurs in response to C fiber inputs. Wind-up is different, however, in that it can be short-lasting, while central sensitization and hyperalgesia persist over time. It is important for you to understand that acute, unrelieved pain leads to chronic pain through central sensitization. Even brief intervals of acute pain can induce long-term neuronal remodeling and sensitization, plasticity, chronic pain, and lasting psychologic distress. Neuroplasticity refers to processes that allow neurons in the brain to compensate for injury and adjust their responses to new situations or changes in their environment. Neuroplasticity contributes to adaptive mechanisms for reducing pain, but can result in maladaptive mechanisms that enhance pain sensitivity. Genetic variability may play a key role in changes that occur in the CNS and the response to different analgesic therapies to treat pain. Understanding this phenomenon helps explain individual differences in response to pain and why some patients develop chronic pain conditions and others do not. Referred pain must be considered when interpreting the location of pain reported by the person with an injury or a disease involving visceral organs. The location of a stimulus may be distant from the pain location reported by the patient, figure 8.3. For example, pain from liver disease often occurs in the right upper abdominal quadrant. It also can be referred to the anterior and posterior neck region, shoulder area, and posterior flank area. If we do not consider referred pain when evaluating a pain location report, diagnostic tests and therapy could be misdirected. Transmission to thalamus and cortex. From the dorsal horn, nociceptive stimuli are communicated to the third-order neuron, primarily in the thalamus. Fibers of dorsal horn projection cells enter the brain through several pathways, including the spinothalamic tract and spinoreticular tract. Distinct thalamic nuclei receive nociceptive input from the spinal cord and have projections to several regions in the cerebral cortex, where the perception of pain is presumed to occur. Therapeutic approaches that target pain transmission include opioid analgesics that bind to opioid receptors on primary afferent and dorsal horn neurons. These agents mimic the inhibitory effects of endogenous opioids. Another medications, baclofen, lioresal, inhibits pain transmission by binding to GABA receptors, thus mimicking the inhibitory effects of GABA. Perception. Perception occurs when pain is recognized, defined, and assigned meaning by the person experiencing the pain. In the brain, nociceptive input is perceived as pain. There is no single precise location where pain perception occurs. Instead, pain perception involves several brain structures. For example, it is thought that the reticular activating system is responsible for warning the person to attend to the pain stimulus. The somatosensory system is responsible for localization and characterization of pain, and the limbic system is responsible for the emotional and behavioral responses to pain. Cortical structures are crucial to constructing the meaning of the pain. Therefore, behavioral strategies such as distraction and relaxation are effective pain-reducing therapies for many people. Meditation and imagery can affect pain perception. By directing attention away from the pain sensation, patients can reduce the sensory and affective components of pain. Modulation. Modulation involves the activation of descending pathways that exert inhibitory or facilitatory effects on the transmission of pain. Figure 8.1. Depending on the type and degree of modulation, nociceptive stimuli may or may not be perceived as pain. Modulation of pain signals can occur at the level of the periphery, spinal cord, brainstem, and cerebral cortex. Descending modulatory fibers release chemicals such as serotonin, norepinephrine, GABA, and endogenous opioids, which can inhibit pain transmission. Several antidepressants exert their effects through the modulatory systems. For example, tricyclic antidepressants, e.g. amitriptyline, and SNRIs, e.g. venlafaxine, are used to manage chronic, non-cancer, and cancer pain. These agents interfere with the reuptake of serotonin and norepinephrine, thereby increasing their availability to inhibit noxious stimuli. Classification of pain. We categorize pain in several ways. Most often, pain is categorized as nociceptive or neuropathic based on underlying pathology, Table 8.3. Another useful scheme is to classify pain as acute or chronic, Table 8.4. Nociceptive pain is caused by damage to somatic or visceral tissue. Somatic pain often is further categorized as superficial or deep. Superficial pain arises from skin, mucous membranes, and subcutaneous tissues. It is often described as sharp, burning, or prickly. Deep pain is often described as aching or throbbing. It originates in bone, joint, muscle, skin, or connective tissue. Visceral pain comes from the activation of nociceptors in the internal organs and lining of the body cavities, such as the thoracic and abdominal cavities. Visceral nociceptors respond to inflammation, stretching, and ischemia. Stretching of hollow viscera in the intestines and bladder that occurs from tumor involvement or obstruction can produce intense cramping pain. Examples of visceral nociceptive pain include pain from a surgical incision, pancreatitis, and inflammatory bowel disease. Neuropathic pain is caused by damage to peripheral nerves or structures in the CNS. Although neuropathic pain is often associated with diabetic neuropathy and other neuropathic pain syndromes, about 8% of the general population has pain with neuropathic characteristics, typically described as numbing, hot, burning, shooting, stabbing, sharp, or electric shock-like. Neuropathic pain can be sudden, intense, short-lived, or lingering. Paroxysmal firing of injured nerves is responsible for shooting and electric shock-like sensations. Common causes of neuropathic pain include trauma, inflammation, metabolic diseases, e.g. diabetes, alcoholism, nervous system infections, e.g. herpes zoster, human immunodeficiency virus, tumors, toxins, and neurologic diseases, e.g. multiple sclerosis. Examples of neuropathic pain conditions include phantom limb sensation, diabetic neuropathy, and trigeminal neuralgia. No single sign or symptom is diagnostic for neuropathic pain. CNS lesions or dysfunction cause central pain. Afferentiation pain results from loss of or altered afferent input secondary to either peripheral nerve injury, e.g. amputation, or CNS damage, including a spinal cord injury. Painful peripheral polyneuropathies, pain felt along the distribution of multiple peripheral nerves, and painful mononeuropathies, pain felt along the distribution of a damaged nerve, arise from damage to peripheral nerves. They generate pain that people may describe as burning, paroxysmal, or shock-like. I'm going to define the word paroxysmal here for reference. From Merriam-Webster, paroxysmal, a sudden attack or spasm, as of a disease. 2. A sudden recurrence of symptoms or an intensification of existing symptoms. patient may have positive or negative motor and sensory signs, including numbness, allodynia, or change in reflexes and motor strength. I'm going to define allodynia here for reference from Merriam-Webster. Pain resulting from a stimulus, such as a light touch of the skin, which would not normally provoke pain. Sympathetically maintained pain is associated with a group of conditions that have a degree of changes in autonomic nervous system. One particularly debilitating type is complex regional pain syndrome, CRPS. Typical features include dramatic changes in the color and temperature of the skin over the affected limb or body part, accompanied by intense burning pain, skin sensitivity, sweating, and swelling. CRPS type 1 is often triggered by tissue injury, surgery, or a vascular event such as stroke. CRPS type 2 includes all of these features and a peripheral nerve lesion. Neuropathic pain is often not well controlled by opioid analgesics alone. Treatment often requires a multimodal approach combining various adjuvant analgesics from different drug classes. These include tricyclic antidepressants, e.g. amitriptyline, SNRIs, e.g. bupropion, Wellbutrin and Zyban, anti-seizure drugs, e.g. pregabalin, Lyrica, transdermal lidocaine, and A2 adrenergic agonists, e.g. clonidine. NMDA receptor antagonists such as ketamine have shown promise in alleviating neuropathic pain refractory to other drugs. Acute and chronic pain. Acute pain and chronic pain differ in their cause, course, manifestations, and treatment. Table 8.4. Examples of acute pain include postoperative pain, labor pain, pain from trauma, e.g. lacerations, fractures, sprains, pain from infection, e.g. dysuria from cystitis, and pain from acute ischemia. I'm going to define ischemia here for reference from Merriam-Webster: deficient supply of blood to a body part, such as the heart or brain, that is due to obstruction of the inflow of arterial blood. For acute pain, treatment includes analgesics for symptom control and treatment of the underlying cause, e.g. splinting for a fracture, antibiotic therapy for an infection. Normally, acute pain decreases over time as healing occurs. However, acute pain that persists can lead to disabling chronic pain states. For example, pain associated with herpes zoster subsides as the acute infection resolves, usually within a month. However, sometimes the pain persists and develops into a chronic pain state called post-therapeutic neuralgia. Because of the connection between inadequately treated acute pain and chronic pain, it is important to treat acute pain aggressively. Chronic pain or persistent pain lasts for longer periods, often defined as longer than 3 months or past the time when an expected acute pain or acute injury should subside. The severity and functional impact of chronic pain often are disproportionate to objective findings because of changes in the nervous system not detectable with standard tests. Although acute pain functions as a signal warning the person of potential or actual tissue damage, chronic pain does not appear to have an adaptive role. Chronic pain can be disabling and often is accompanied by anxiety and depression. Pain assessment. Assessment is an essential, although often overlooked, step in pain management. Regularly screen all patients for pain, and when present, perform a more thorough pain assessment. The key to accurate and effective pain assessment is to consider the principles of pain assessment, Table 8.5. The goals of a nursing pain assessment are to 1. Describe the patient's pain experience, to identify and implement appropriate pain management techniques, and 2. Identify the patient's goal for therapy and resources for self-management. Elements of a pain assessment. Most components of a pain assessment involve direct interview or observation of the patient. Diagnostic studies and physical examination findings complete the initial assessment. Although the assessment differs according to the clinical setting, patient population, and point of care, i.e., whether the assessment is part of an initial workup or a reassessment of pain following therapy, the evaluation of pain should always be multidimensional. Table 8.6. Before beginning any assessment, recognize that patients may use words other than pain. For example, older adults may deny that they have pain but respond positively when asked if they have soreness or aching. Document the specific words that the patient uses to describe pain. Then, consistently ask the patient about pain using those words. Pain pattern. Assessing pain onset involves determining when the pain started. Patients with acute pain resulting from injury, acute illness, or treatment, e.g. surgery, typically know exactly when their pain began. Those with chronic pain may be less able to relate when the pain started. Establish the duration of the pain, how long it has lasted. This information helps to determine whether the pain is acute or chronic and helps identify the cause of the pain. For example, a patient with advanced cancer who has chronic low back pain from spinal stenosis reports a sudden, severe pain in the back that began 2 days ago. Knowing the onset and duration can lead to a diagnostic workup and may reveal new metastatic disease in the spine. The pain pattern gives clues about the cause of the pain and directs its treatment. Many types of chronic pain, e.g. arthritis pain, can increase and decrease over time. A patient may have pain all the time, around-the-clock pain, as well as discrete periods of intermittent pain. Breakthrough pain, BTP, is transient, moderate to severe pain that occurs in patients whose baseline persistent pain is otherwise mild to moderate and fairly well controlled. The average peak of BTP can be 3 to 5 minutes and can last up to 30 minutes or even longer. BTP can be either predictable or unpredictable. Patients can have 1 to many episodes per day. Several transmucosal fentanyl products are used specifically to treat BTP. End-of-dose failure is pain that occurs before the expected duration of a specific analgesic. It should not be confused with BTP. Pain that occurs at the end of the duration of an analgesic often leads to a prolonged increase in the baseline persistent pain. For example, in a patient on transdermal fentanyl, Duragesic patches, the typical duration of action is 72 hours. An increase in pain after 48 hours on the drug would be an end-of-dose failure. End-of-dose failure signals the need for changes in the dose or scheduling of the analgesic. Episodic, procedural, or incident pain is a transient increase in pain that is caused by a specific activity or event that precipitates pain. Examples include dressing changes, movement, position changes, and procedures, such as catheterization. Location. Determining the location of pain helps us identify possible causes and treatment. Some patients may be able to specify the precise locations of their pain. Others may describe general areas or comment that they hurt all over. The location of the pain may be referred from its origin to another site. Figure 8.3. For example, myocardial infarction can result in pain in the left shoulder. Pain can radiate from its origin to another site. For example, angina pectoris can radiate from the chest to the jaw or down the left arm. We refer to this as radiating pain. Sciatica is pain that follows the course of the sciatic nerve. It may originate from joints or muscles around the back or from compression or damage to the sciatic nerve. The pain is projected along the course of the peripheral nerve, causing painful shooting sensations down the back of the thigh and inside of the leg to the foot. Obtain information about the location of pain by asking the patient to 1. Describe the sites of pain, 2. Point to painful areas of the body, or 3. Mark painful areas on a pain map. Because many patients have more than one site of pain, make certain that the patient describes every location. Intensity. Assessing the severity or intensity of pain provides a reliable measure to determine the type of treatment and its effectiveness. Pain scales help the patient communicate pain intensity. Base your choice of a scale on the patient's developmental needs and cognitive status. Figure 8.4. Most adults can rate the intensity of their pain using a numeric rating scale, e.g. 0 equals no pain, 10 equals the worst pain. Patients who wish to word choices to quantify pain may prefer a verbal descriptor scale, e.g. none, mild, moderate, severe. For those oriented to vertical representations, the pain thermometer scale is an option. Other visual pain measures, such as the Wong-Baker Faces pain tool, are useful for patients with cognitive or language barriers to describe their pain. Pain assessment measures for cognitively impaired adults and nonverbal adults are addressed later in this chapter. Although intensity is an important factor in determining analgesic approaches, do not dose patients with opioids solely based on reported pain scores. Opioid dosing by numbers, without considering a patient's sedation level and respiratory status, can lead to unsafe practices and serious adverse events. Safer analgesic administration can be achieved by balancing an amount of pain relief with analgesic side effects and using a multimodal approach. Multimodal approach is described later in this chapter. Adjustments in therapy can be made to promote better pain control and minimize adverse outcomes. Quality. The pain quality refers to the nature or characteristics of the pain. For example, patients often describe neuropathic pain as burning, numbing, shooting, stabbing, electric shock-like, or itchy. Nociceptive pain may be described as sharp, aching, throbbing, dull, and cramping. Since the quality of pain relates to a degree to the classification of pain, e.g. neuropathic or nociceptive, these descriptors can help to guide treatment options that best address the specific mechanism of pain. Associated symptoms. Associated symptoms, such as anxiety, fatigue, and depression, may worsen or be worsened by pain. Patients with pain often report poor sleep and subsequent daytime sleepiness. Poor sleep can further increase pain perception. Ask about aggravating factors that increase pain, as well as activities and situations that alleviate pain. For example, musculoskeletal pain may be increased or decreased with movement and ambulation. Resting or immobilizing a painful body part can decrease pain. Knowing what makes pain better or worse can help characterize the type of pain and be helpful in selecting treatments. Management strategies. As people experience and live with pain, they may cope differently and be more or less willing to try different strategies to manage it. Some strategies are successful while others are not. To maximize the effectiveness of the pain treatment plan, ask patients what they are using now to control pain, what they have used in the past, and the outcomes of these methods. Strategies include prescription and non-prescription drugs and non-drug therapies, such as hot and cold applications, complementary and alternative therapies, e.g. acupuncture, and relaxation strategies, e.g. imagery. It is important to document both those that work and those that are ineffective. Impact of pain. Pain can have a profound influence on a patient's quality of life and functioning. Assess the effect of the pain on the patient's ability to sleep, enjoy life, interact with others, perform work and household duties, and engage in physical and social activities. Assess the impact of pain on the patient's mood. In an acute care setting, time limitations may dictate a shortened assessment. At a minimum, Assess the effects of the pain on the patient's sleep and daily activities, relationships with others, physical activity, and emotional well-being. Include the ways in which the patient describes the pain and strategies used to cope with and control the pain. Patient's beliefs, expectations, and goals. Patient and family beliefs, attitudes, and expectations influence responses to pain and pain treatment. Assess for attitudes and beliefs that may hinder effective treatment, e.g., belief that opioid use will result in addiction. Ask about expectations and goals for pain management. Documentation. Document the pain assessment since this is critical to ensure safe, effective communication among interprofessional team members. Many healthcare facilities have adopted specific tools to record an initial pain assessment, treatment, and reassessment. There are also many multidimensional pain assessment tools, such as the Brief Pain Inventory, the McGill Pain Questionnaire, and the Neuropathic Pain Scale. Reassessment. It is critical for you to reassess pain at appropriate intervals. The frequency and scope of reassessment are guided by factors such as pain severity, physical and psychosocial condition, type of intervention and risks for adverse effects, and institutional policy. For example, reassessment of a postoperative patient may be done frequently, such as at the time of peak effect for each analgesic dose. In a long-term care facility, residents with chronic pain are reassessed at least quarterly or with a change in condition or functional status. Pain treatment. Basic principles. All pain treatment plans are based on the following 10 principles and practice standards. Number 1. Follow the principles of pain assessment, Table 8.5. Remember that pain is a subjective experience. The patient is not only the best judge of his or her own pain, but also the expert on the effectiveness of each pain treatment. 2. Use a holistic approach to pain management. The pain experience affects all aspects of a person's life. Thus, a holistic approach to assessment, treatment, and evaluation is required. 3. Every patient deserves adequate pain management. Many patient populations, including ethnic minorities, cognitively impaired adults, and people with past or current substance abuse, are at risk for inadequate pain management. Be aware of your own biases and ensure that all patients are treated respectfully. Number 4. Base the treatment plan on the patient's goals. Discuss with the patient realistic goals for pain relief during the initial pain assessment. Although goals can be described in terms of pain intensity, e.g., the desire for average pain to decrease from 8 out of 10 to 3 out of 10, with chronic pain conditions, encourage functional goal setting, e.g., a goal of performing certain daily activities such as socializing and recreational activities. Encourage functional activities for the patient with acute pain as well. For example, the pain must be at a level that allows the patient to use the incentive spirometer, get out of bed, and ambulate. Over time, reassess these goals and progress made towards meeting them. The patient, in collaboration with the interprofessional team, determines new goals. If the patient has unrealistic goals for therapy, such as wanting to be completely rid of all chronic arthritis pain or be completely pain-free after a major surgery, work with the patient to establish a more realistic goal. Number 5. Use both drug and non-drug therapies. Although drugs are considered the mainstay of therapy, include self-care activities and non-drug therapies to increase the overall effectiveness of therapy and to allow the reduction of drug dosages to minimize adverse drug effects. Number 6. When appropriate, use a multimodal approach to analgesic therapy. Multimodal analgesia employs the use of 2 or more classes of analgesic agents to take advantage of the various mechanisms of action. For acute postoperative pain, a multimodal approach may include the use of an opioid, morphine, non-opioid, non-steroidal anti-inflammatory drug, and/or anti-seizure drug, e.g. gabapentin. Regional anesthesia and continuous peripheral neural blockade can be used with local anesthetics as part of multimodal regimens. Factors such as age, type of surgery, risk for developing chronic pain, and coexisting conditions are all considered when designing a multimodal analgesic regimen. Multimodal analgesia is used to treat chronic or persistent pain. Similar to the strategies for acute postoperative pain, the goal is to combine classes of analgesics for the maximum benefit of relieving pain with minimum doses to achieve relief and reduce adverse events from analgesics. Multimodal regimens achieve superior pain relief, enhance patient satisfaction, and decrease adverse effects of individual drugs. 7. Address pain using an interprofessional approach. The expertise and perspectives of an interprofessional team are often necessary to provide effective assessment and therapies for patients with both acute and chronic pain. For hospitalized patients or those with complex acute or chronic pain issues, anesthesiology-based pain services may be available to manage patients with technology-supported pain care, e.g., patient-controlled analgesia or regional analgesia. Team members for these services can include pain management nurses, nurse practitioners, clinical nurse specialists, anesthesiologists, and clinical pharmacists. These teams help to establish realistic goals with patients and families to facilitate recovery and discharge. Many outpatient pain management centers or clinics are available. Some provide comprehensive pain care and employ multiple providers, including anesthesiologists, rehabilitation physicians, nurses, psychologists, physical and occupational therapists, and social workers. Services may focus on medication management, pain interventional therapies, psychologic counseling, cognitive and behavioral therapies, rehabilitative therapies, physical and occupational therapy, and social services. Specialized pain treatment centers may also offer more holistic therapies such as massage, music and art therapy, and acupuncture. Advise patients seeking specialized pain care from outpatient treatment centers to check about services that are provided. 8. Evaluate the effectiveness of all therapies to ensure that they are meeting the patient's goals. Achievement of an effective treatment plan often requires trial and error. Adjustments in drug, dosage, or route are common to achieve maximal benefits while minimizing adverse effects. This trial and error process can become frustrating for the patient and caregivers. Reassure them that pain relief, if not pain cessation, is possible and that the interprofessional team will continue to work with them to achieve adequate pain relief. 9. Prevent and/or manage medication side effects. Side effects or adverse events are a major reason for treatment failure and non-adherence. Side effects are managed in one of several ways as described in Table 8.7. You play a key role of monitoring for and treating side effects and in teaching patients and caregivers how to minimize these effects. 10. Include patient and caregiver teaching throughout assessment and treatment. Content should include information about the causes of pain, pain assessment methods, treatment goals and options, expectations of pain management, proper use of drugs, side effect management, and non-drug and self-help pain relief measures. Document the teaching and include evaluation of patient and caregiver comprehension. Drug therapy for pain. Pain medications generally are divided into three categories: non-opioids, opioids, and adjuvant drugs. Patient-centered treatment regimens may include medications from one or more of these groups. Mild pain often can be relieved using non-opioids alone. Moderate to severe pain usually requires an opioid. Certain types of pain, such as neuropathic pain, typically require adjuvant drug therapy alone or in combination with an opioid or another class of analgesics. Pain caused by cancer may be treated with chemotherapy or radiation therapy as well as pain medications. Non-opioids. Non-opioid analgesics include acetaminophen, aspirin, and other salicylates, and Nsaids, Table 8.8. These agents are characterized by 1. Their analgesic properties having an analgesic ceiling, that is, increasing the dose beyond an upper limit provides no greater analgesia. 2. They do not produce tolerance or physical dependence. And 3. Many are available without a prescription. To provide safe care, monitor over-the-counter analgesic use to avoid serious problems related to drug interactions, side effects, and overdose. Non-opioids are effective for mild to moderate pain. They are often used in conjunction with opioids because they allow for effective pain relief using lower opioid doses, thereby causing fewer opioid side effects. This phenomenon is called opioid sparing effect. Aspirin is effective for mild pain, but its use is limited by its common side effects, including increased risk for bleeding, especially gastrointestinal bleeding. Other salicylates, such as choline magnesium trisalicylate or trilosate, cause fewer GI problems and bleeding abnormalities. Similar to aspirin, acetaminophen Tylenol has analgesic and antipyretic effects. Unlike aspirin, it has no antiplatelet or anti-inflammatory effects. Acetaminophen is well tolerated. It is metabolized by the liver. Hepatotoxicity may result from chronic dosing of more than 3 grams per day, acute overdose, or use by patients with severe pre-existing liver disease. Adding Tylenol to opioid therapy produces an opioid-sparing effect, lower pain scores, and fewer side effects. This is the reason for opioid acetaminophen combinations. IV acetaminophen, or Afferent, is used alone for the treatment of acute mild to moderate pain and as an adjunct to opioid analgesics or part of a multimodal analgesic regimen for moderate to severe pain. It must be given over 15 minutes and has a short duration of action. The daily dose should not exceed 4 grams a day. Nsaids represent a broad class of drugs with varying efficacy and side effects. All Nsaids inhibit COX, the enzyme that converts arachidonic acid into prostaglandins and related compounds. The enzyme has 2 forms, COX-1 and COX-2. COX-1 is found in almost all tissues. It is responsible for several protective physiologic functions. In contrast, COX-2 is made mainly at the sites of tissue injury, where it mediates inflammation. Figure 8.5. Inhibition of COX-1 causes many of the untoward effects of Nsaids, such as impairment of renal function, bleeding tendencies, GI irritation, and ulceration. COX-2 inhibition is associated with the therapeutic anti-inflammatory effect of Nsaids. Celecoxib, or Celebrex, is a COX-2 inhibitor. Older Nsaids, such as ibuprofen, inhibit both forms of COX. We refer to them as non-selective Nsaids. Patients vary greatly in their responses to a specific Nsaid, so when one Nsaid does not provide relief, another should be tried. Nsaids are associated with many side effects, including GI problems ranging from dyspepsia to life-threatening ulceration and hemorrhage. Nsaids can cause cognitive impairment and hypersensitivity reactions with asthma-like symptoms. Patients at risk for Nsaid-associated GI toxicity include those who have a recent history of peptic ulcer disease, patients who are older than 65, and those concurrently using corticosteroids or anticoagulants. If Nsaids are used in patients at risk for GI bleeding, they should have concomitant therapy with misoprostol, Cytotec, or a proton pump inhibitor such as omeprazole. Nsaids should not be given concurrently with aspirin, since this increases the risk for GI bleeding. Opioids. Opioids, Table 8.9, produce their effects by binding to receptors in the CNS. And just a quick note, that table is huge. It takes up an entire page, and we should probably look at it later. This results in 1. Inhibition of the transmission of nociceptive input from the periphery to the spinal cord, 2. Altered limbic system activity, and 3. Activation of the descending inhibitory pathways that modulate transmission in the spinal cord. Thus, opioids act on several nociceptive processes. Types of opioids. Opioids are categorized according to their physiologic action, i.e. agonist, antagonist, and binding at specific opioid receptors, e.g. mu, kappa, delta. The most commonly given subclass of opioids is the pure opioid agonists, or morphine-like opioids, which bind to mu receptors, that's mu, M-U. Opioid agonists are used for acute and chronic pain. Although nociceptive pain seems to be more responsive to opioids than neuropathic pain, opioids may be used to treat both types of pain. In the treatment of neuropathic pain, anti-neuropathic pain drugs, such as antidepressants and anti-seizure drugs, are recommended as first-line agents. Pure opioid agonists include morphine, oxycodone or oxycontin, hydrocodone, codeine, methadone, hydromorphone or Dilaudid, and levorphenol. Table 8.9. These drugs are effective for moderate to severe pain because they are potent, theoretically have no analgesic ceiling, and can be given by several routes. When opioids are prescribed for moderate pain, they are usually combined with a non-opioid analgesic, such as acetaminophen with codeine or hydrocodone plus acetaminophen or ibuprofen. Adding acetaminophen limits the total daily dose that we can give. So we have some drug alerts that are kind of sprinkled about this page. One was up above about Nsaids. We got one here for morphine and another one for methadone, so take a look at those. Methadone has a unique mechanism of action as an NMDA receptor antagonist and mu opioid receptor agonist. It is used primarily in the treatment of chronic pain, but can be used for acute pain. It produces analgesic effects independent of its action as an opioid. So just for reference, I'm going to revisit what an agonist versus an antagonist is. An agonist is like a copycat, which binds to the receptor and produces a similar response to the intended chemical and receptor, so agonist, copycat. Whereas an antagonist is a drug that binds to the receptor either on the primary site or on another site, which altogether stops the receptor from producing a response. So it's just a blocker. Cuts off any reaction. So agonist, copycat, initiates a similar reaction. Antagonist, dead stop. Mixed agonist antagonists, e.g. pentazocine, Talwin, or butorphanol, bind as agonists on kappa receptors and as weak antagonists or partial agonists on mu receptors. Because of this difference in binding, mixed agonist-antagonists produce less respiratory depression than drugs that act only at mu receptors. These drugs cause more dysphoria and agitation. In addition, opioid agonist-antagonists have an analgesic ceiling and can precipitate withdrawal if used by a patient who is physically dependent on mu agonist drugs. Partial opioid agonists, e.g. buprenorphine or Buprenex, can produce some pain relief but bind tightly to mu receptors